So one of the things that I'm very excited about what we're doing in New York is moving to a comprehensive system of integrated care where everyone is taking responsibility mutually for the health outcomes and other outcomes that a patient or client or consumer, however you define them, is looking for. So for example, in New York, we've for a long time required clinicians to report on retention in care and viral suppression for people with HIV. We're now expanding that. First of all, clinicians aren't just responsible for their specific HIV program in a medical center. They're responsible for every single HIV positive person who comes into that medical center, whether it's through the emergency room or through a methadone clinic. And now we're rolling it out and making every non-clinician responsible for viral suppression. Because when you think about it, it's always been the clinician's responsibility that somebody stay adherent to their medication. Clinicians interact with the patient like maybe 4 times a year. You have a case manager or a supportive housing provider who's interacting with that person weekly, daily. So why can't they own part of the responsibility for treatment adherence and viral suppression? And so I think that's a perfect example of how it interfaces. Having clinicians thinking about the fact that if somebody's sleeping in a shelter, taking their medication is going to be a different experience, and they might need different arrangements than if they have a safe home to go to. Do people have electricity? Do people have refrigeration? Are people eating regular meals? And if not, what can we do to facilitate that? Because if you're not eating regular meals, how do you take medications that you have to take with food? So it's as simple as beginning to think about those sort of things. We know that when it comes to treatment adherence, people have better outcomes if they're housed, but it doesn't just accidentally happen. There has to be some intentionality around that. We know that people who are on medication do better with adherence if they have a vocational activity that they're involved in, whether it's going to school, being a volunteer, or working a full-time job. All of those things have to come together if we're going to end the epidemic. And that means, for example, thinking about the discrimination that transgender people face, not just in the healthcare system, which is big, and how do we overcome that, but how do we overcome discrimination for transgender people when it comes to housing, when it comes to employment. Fortunately, I come from a state where just this last year, our governor signed an executive order providing comprehensive transgender rights, all of the human rights protections that we have in New York State for other populations in public accommodation. But not every state does that, and in fact some states like North Carolina overtly discriminate against transgender people. So how do we engage those folks in care, and not only engage them in care, but join with them in fighting to change the systemic oppression that keeps them shut out? And I think that's kind of fundamental. You know, even in New York, if you talk to transgender people, whether they're at risk and you want them to go on PrEP, or they're HIV positive and you want them to be virally suppressed, you know, it's really easy for folk to start thinking all they care about me is, am I taking my pills? They don't care about, do I have a place to sleep? They don't care about the fact that I get heckled and harassed every time I walk down the street. They don't care about the fact that I go into my medical clinic and the receptionist calls me Mr. When obviously I'm female. All of those things. And so to us, that's all a part of the transformation that we need to achieve to end the epidemic. When it comes to medical interventions, we're pretty advanced. We're not exactly where we need to be, and there's some continued improvements just on the treatment and prevention side with technology that we need to get. And that's even before you talk about something like a vaccine or a cure. But the fact of the matter is that we do have pre-exposure prophylaxis. Right now there's only one drug, but there's other drugs in development that will do the same thing. If you take this one pill consistently at least 4 times a week, it's prescribed for 7 times a week. If you take that pill, you're not going to get HIV. It's 99.9% guaranteed that you're immune to the virus. As far as treatment goes, we have dozens of combinations now available for treatment of people with HIV. And certainly here in the United States, one of the points that I think is important to make is that there is no one living with HIV in this country who shouldn't have access to a treatment combination that works for them. And so that's why we formed this national coalition, Act Now End AIDS, because what we know is that if we can get everyone who's HIV positive virally suppressed and on the right treatment regimens that work, provide them the services that they need and care that they need to stay adherent to that, we can not only end transmission, but we can end progression from HIV to AIDS, and we can end AIDS mortality. It's that simple. It really is. And if at the same time, knowing that we won't ever get 100% viral suppression, if we can at the same time expand prevention, including pre-exposure prophylaxis, post-exposure prophylaxis, so that they're universally accessible to people at risk, expand syringe exchange. It is just a damnable shame that there are so many people injecting drugs around this country who don't have access to clean syringes, much less harm reduction services, which are going to be more effective than traditional drug treatment in getting them to a place where they can live their lives whole, in addition to not contracting HIV, hepatitis C, and other diseases that go along with shared syringe use and other diseases that go along with various types of drug use that don't involve syringes.